If you're over 60 and you take a daily medication, even one you've been on for years, even one your doctor says is perfectly safe, there is a real chance it is quietly damaging your bowel right now. Not causing pain, not giving you obvious symptoms, just slowly, silently changing the structure of your gut in ways that may take years to show up as something serious. 7 medications are doing this. Not rare drugs, not experimental drugs, medications sitting in medicine cabinets across this country. And the reason most people don't know is not because their doctor is careless. It's because the damage is invisible until it isn't. And by then, it looks like something else entirely. By the end of this video, you will know exactly which drugs these are, why they cause the damage they do, and the one conversation you can have with your doctor that most patients never know to ask for. My name is Dr. Stephen Marlowe. I've spent years working with adults over 60 on exactly these questions, the ones that don't make it into a 10-minute appointment. Your doctor is not wrong to have you on these medications. Most of them are doing exactly what they're supposed to do. What they didn't have time to tell you is what those same medications are doing to one system they may not be watching closely enough. Before I name a single medication, I need to tell you something that almost no video on this topic explains, because it is the reason these drugs hit harder in your 60s and 70s than they ever did before. Your bowel has already changed. After the age of 60, the colon undergoes a series of structural changes that researchers now understand far better than they did even a decade ago. The goblet cells that line your colon wall and produce the thick mucus layer acting as your gut's first line of defense begin to decline in number. Less mucus means less protection. The protective barrier between your gut contents and your bloodstream becomes thinner. At the same time, the pacemaker cells of the gut, the ones that coordinate the rhythmic wave of muscle contractions that moves everything through, reduce in number too. Slower signaling, slower transit. The colon that used to move efficiently in 24 hours may now take 48 or 60. And something else is happening at the immune level. Researchers call it inflammaging, a state of low-grade chronic background inflammation that develops in the gut as we age. When a medication arrives in this environment, it is not landing on a healthy, resilient system with full reserves. It is landing on a system already operating with reduced capacity and reduced protection. This is why a medication that gave your neighbor mild bloating in their 40s can produce something genuinely dangerous in your 60s. The underlying system is structurally different. Keep that picture in your mind as we go through each medication, because every one of these drugs is not hitting a healthy gut, it's hitting that one. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. These are some of the most prescribed medications in the world, and for decades, they carried a reputation as among the safest drugs in medicine. Here is what the research published in the last 3 years actually shows. Your stomach is designed to be highly acidic. That acid acts as a chemical barrier, killing pathogenic bacteria before they reach your intestines. When a PPI chronically suppresses that acid, it raises the pH of your entire digestive tract, and that change allows bacteria that should never get past your stomach to travel further into your small intestine and colon. A clinical study found that 43% of elderly patients taking omeprazole daily developed small intestinal bacterial overgrowth, or SIBO. Nearly half of elderly patients on a daily omeprazole had it. Research from the Medical University of Graz confirmed that long-term PPI use increases gut permeability, what is sometimes called leaky gut. The lining of your intestine develops microscopic gaps that allow bacterial fragments called endotoxins into your bloodstream, triggering low-grade systemic inflammation. And a 2025 study in Frontiers in Microbiology linked long-term PPI use to the development of ulcerative colitis through the chronic alteration of the gut microbiome. The drug prescribed to protect your gut lining may be reshaping the bacterial ecosystem that maintains it. PPIs have a real role in medicine. They prevent upper GI bleeds and treat genuine acid reflux disease. The problem is that a landmark study found 65 to 70% of elderly patients on long-term PPIs had no real clinical indication for acid-lowering therapy at the time. The majority of this damage may be happening in people who don't actually need the drug anymore. If you've been on a PPI for more than 8 weeks, the question to ask is simple. Do I still need this at this dose for this long? Have you ever been told you have acid reflux, been put on a PPI, and just never been taken off it? Nobody came back to reassess. It became part of the routine. Tell me in the comments, because you are not alone, and your answer shapes what I cover next. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac, aspirin above 325 milligrams. These are the drugs most people over 60 reach for joint pain, back pain, arthritis pain. Many are available without a prescription. Most people have no idea they have a bowel damage profile. NSAIDs were originally associated with upper GI damage, stomach ulcers, and bleeding. When pharmaceutical companies developed enteric-coated formulations, the goal was to reduce stomach exposure. They succeeded. What they didn't anticipate is that the damage moved downstream to the small intestine and colon, where it is harder to detect and almost never visible on a standard upper endoscopy. NSAIDs suppress prostaglandins, chemicals that maintain the mucosal lining of the gut and regulate blood flow to the colon wall. Reduce prostaglandins chronically, and you reduce the gut's ability to protect itself, and you reduce blood flow to the tissue lining your colon. That reduced blood flow can lead to a condition called ischemic colitis. Tissue in the colon, starved of adequate blood supply, begins to die. An analysis of the FDA's Adverse Event Reporting System found that drug-induced ischemic colitis resulted in hospitalization in nearly 47% of cases, and death in almost 10%. Adults over 65 represented 34% of those cases. This is not a theoretical risk. It is a documented, hospitalization-causing condition triggered by medications most people consider mild. A 2023 review confirmed that NSAID-associated colitis can clinically mimic inflammatory bowel disease and Crohn's disease. An unknown number of patients may be carrying an IBD diagnosis when the actual cause is a medication they are still taking. There is one more thing about NSAIDs I'll come back to shortly, because when combined with a commonly prescribed antidepressant, they create a GI bleeding risk that is not simply the sum of both drugs. Antidepressants, sertraline, fluoxetine, escitalopram, prescribed to millions of adults over 60 for depression, anxiety, and sleep. There is a bowel consequence of this entire drug class that most prescribers never mention. Here is the biological fact that explains everything. Approximately 95% of your body's total serotonin is not in your brain. It's in your gut, produced by specialized cells in the lining of your intestines. Serotonin in the gut drives peristalsis. It is the chemical signal that tells your intestinal muscles to contract and move things forward. When you take an SSRI, it is not just altering neurochemistry in your brain. It is altering serotonin dynamics in the system that contains 95% of your body's serotonin. This is why GI side effects are not an occasional nuisance with antidepressants. They are the most pharmacologically predictable consequence of the drug. SSRIs also affect platelets. Platelets carry serotonin and use it during the clotting process. When a blood vessel in your gut wall is injured, platelets aggregate and form a clot. SSRIs deplete the serotonin stored in platelets, which impairs clotting at injury sites in the gut wall. A 2025 meta-analysis confirmed that SSRIs independently increase GI bleeding risk through this platelet mechanism. Now here is the combination. NSAIDs strip the mucosal lining and reduce blood supply. SSRIs impair clotting at the exposed blood vessel. When you combine them, the bleeding risk is substantially, meaningfully greater than either drug alone. This combination, A daily aspirin or ibuprofen alongside a daily SSRI is one of the most common drug pairs in adults over 60. Most patients on both have never been warned. If you are on both, this is a specific question for your prescriber. Has my combined GI bleeding risk from these two medications been assessed? Opioids: hydrocodone, oxycodone, codeine, tramadol. The bowel effect most people have heard of is constipation. What most people don't know is that opioid-induced constipation is only one component of a broader syndrome, and the standard approach to treating it usually doesn't work, for a specific reason. Opioids bind to mu-opioid receptors throughout the nerve network embedded in your gut wall. When those receptors are occupied, the entire system slows. Peristalsis reduces, gastric emptying slows, fluid secretion decreases, and anal sphincter tone increases. Researchers call this opioid-induced bowel dysfunction. It encompasses abdominal cramping, bloating, reflux, nausea, and hard, difficult stool. Between 40 and 90% of patients on opioid therapy experience some form of this syndrome. Here is why standard laxatives frequently fail. They act on the colon lining or draw water in. They do not address the mu-opioid receptors causing the dysfunction. The mechanism is still fully active. The laxative is managing the surface while the underlying problem continues entirely undisturbed. There is a class of medications that actually addresses the mechanism, called PAMRAs, which block opioid receptors specifically in the gut without crossing the blood-brain barrier. They don't interfere with pain control, and most patients on long-term opioids have never been offered them or told they exist. If you are on a long-term opioid and a laxative isn't working, that is not a personal failure. It is a pharmacological consequence, and there is a medication specifically designed for it that your prescriber can discuss with you. Metformin is one of the most prescribed medications in the world for type 2 diabetes. It is effective and important, and there is a consequence of long-term use that was only fully understood in research published in January 2023. Metformin appears to increase the uptake of B12 by E. coli bacteria in the terminal ileum, the final section of the small intestine, which is exactly where B12 is absorbed. In the presence of metformin, gut bacteria become more aggressive competitors for vitamin B12. They are, in a meaningful sense, taking what your body needs. Multiple studies document B12 deficiency in between 20 and 41% of long-term metformin users. And in elderly diabetic patients, this deficiency has a presentation that is routinely missed. It does not show up first as anemia. In older adults, B12 deficiency presents first as peripheral neuropathy, tingling and numbness in the feet and hands, and as cognitive changes, memory, concentration, processing speed. These symptoms in a 70-year-old diabetic get attributed instantly to diabetes progression or normal aging. The underlying B12 deficiency, a direct, measurable, addressable consequence of the medication, goes untested. The American Diabetes Association now recommends periodic B12 monitoring for all long-term metformin users. If you have been on metformin for more than a year and your B12 level has never been checked, that is a specific request you can make at your next appointment. This is not a reason to stop metformin. It is a reason to monitor and to supplement if needed, which is simple and inexpensive. Calcium channel blockers are prescribed for high blood pressure and heart rhythm conditions: verapamil, diltiazem, amlodipine. These drugs work by blocking calcium from entering muscle cells. In the heart and blood vessels, that is precisely what you want. The problem is that the same calcium channels they block are responsible for the rhythmic contraction of your intestinal smooth muscle. Research published in 2025 explained this directly. Blockade of L-type calcium channels in intestinal smooth muscle cells impairs peristalsis, the wave of contractions that moves stool through the colon. The drug is slow in your gut not as an accidental side effect. It is the mechanism of the drug, operating in the wrong place. A UK biobank study from Imperial College London found that non-dihydropyridine calcium channel blockers, specifically verapamil and diltiazem, were associated with significantly increased risk of diverticulosis, the development of permanent pouches in the colon lining. These are structural changes that do not resolve when the drug is stopped. Diuretics contribute through a different mechanism. They increase urinary excretion of potassium, and low potassium impairs smooth muscle function throughout the body, including the gut. The combination of a calcium channel blocker and a diuretic is one of the most common pairings in elderly cardiology patients, and it creates a compounding bowel slowing effect that neither drug alone fully accounts for. If you are managing blood pressure and experiencing significant constipation, it is worth asking your prescriber specifically about ACE inhibitors or ARBs, which have a less bowel disruptive mechanism. The final medication on today's list is one many people don't think of as a medication at all, because it's available over the counter and marketed as natural. Stimulant laxatives, Senna, bisacodyl, Cascara. These work by stimulating the nerve endings in the colon wall, triggering contractions, and producing a bowel motion. For short-term use, they have a role. The problem is what happens when they are taken regularly over months and years. Your colon wall contains a network of neurons called the myenteric plexus. This nerve network detects when the colon is full, coordinates the timing and strength of contractions, and manages the entire mechanical process of moving stool forward. Chronic stimulation of the myenteric plexus can damage the neurons themselves. The nerve network becomes less responsive, less coordinated, and eventually unable to initiate movement without the artificial stimulus. This is called laxative colon. The reason you need the laxative more frequently and at higher doses to get the same effect is not because your body is weak. It is because the drug has progressively injured the neural infrastructure that makes spontaneous bowel movement possible. For those who want to step off stimulant laxatives, the first step most gastroenterologists recommend is transitioning to osmotic laxatives, such as polyethylene glycol or lactulose, which draw water into the colon rather than stimulating the nerve network. The colon has capacity for some recovery, but this is a conversation for your doctor, not something to navigate alone. There is also a visible marker of long-term stimulant laxative use called melanosis coli, a brownish pigmentation of the colon mucosa visible on colonoscopy. It can persist for up to a year after stopping, and its relationship to cancer risk is still being actively studied. Now, I want to bring something together that connects across every medication we have discussed today. Microscopic colitis is a chronic inflammatory bowel condition that causes persistent, watery, non-bloody diarrhea, sometimes 4 to 10 episodes a day. The colon during colonoscopy looks completely unremarkably normal. The diagnosis can only be made by taking targeted biopsies from tissue that appears healthy and examining those biopsies under a microscope. Without that specific step, the condition is invisible to conventional investigation, and the medications most strongly implicated in causing or triggering microscopic colitis are PPIs, SSRIs, NSAIDs, ACE inhibitors, and beta blockers, the 5 drug classes most commonly prescribed to adults over 60 in combination. Researchers confirm that microscopic colitis is consistently misdiagnosed as irritable bowel syndrome because it presents the same way. The colonoscopy is normal, and most patients are never referred for biopsy. If you have been told you have IBS, you are on one or more of the medications on today's list, and your symptoms have never fully resolved, that history is worth revisiting with a gastroenterologist. The specific words to use: I would like to rule out microscopic colitis. Can we take biopsies at my next colonoscopy? Here is the thing that changes everything on this list. Every medication I have described today has a documented bowel damage profile on its own. But the majority of adults over 60 are not on one of these medications. The majority are on 3, 4, 5, or more simultaneously. A 2023 study from Oxford University confirmed that polypharmacy with a high drug burden index alters the gut microbiome in ways that override the changes caused by aging alone. And the microbiome did not return to its pre-treatment composition, even after 12 months of having drugs removed. A 2025 study in Frontiers in Aging confirmed that 24% of all marketed drugs inhibit at least one common intestinal microbiome bacterial strain, including non-antibiotic medications like statins and ACE inhibitors. In nursing home settings, elderly patients average more than 7 medications daily. This is a reason to know about deprescribing, a formal medical practice in which a physician systematically reviews the entire medication list, identifies drugs no longer necessary, and reduces the total burden in a supervised, evidence-based way. Most patients don't know they can ask for this review. Many medications are continued by default, rather than by design. The question to ask: would you be willing to do a medication review to see if any of my current prescriptions could be reduced, stopped, or switch to something with a gentler gut profile? Let me give you 5 specific steps you can take from this video. Step 1. Write down every medication you take, prescription and over-the-counter, and ask your pharmacist, is anything on my current list on the Beers criteria? And if so, is there a safer alternative? The Beers criteria is a publicly available, evidence-based list of medications considered potentially inappropriate for adults over 65. Step 2. If you have been on a proton pump inhibitor for more than 8 weeks, ask your prescriber, do I still need this at this dose for this duration? Many patients are on PPIs by inertia rather than ongoing clinical need. Step 3. If you have been on metformin for more than a year, ask for a B12 blood test. Do not wait for symptoms. By the time neurological symptoms appear, the deficiency has often been present for months or years. Step 4. If you are on both an SSRI and a daily NSAID, ask your prescriber directly. Has my combined GI bleeding risk from these 2 medications been assessed? Step 5. If you have experienced persistent watery diarrhea attributed to IBS, and you are on a PPI, an SSRI, or an NSAID, ask your gastroenterologist specifically about microscopic colitis and whether biopsies should be taken at your next colonoscopy. These are not aggressive questions. They are the questions a well-informed patient asks, and every one of them is a conversation your doctor will recognize as legitimate and appropriate. One important note before I close. Some of the medications we discussed today, particularly PPIs, SSRIs, and blood pressure medications, should never be stopped abruptly without medical supervision. Stopping suddenly can cause rebound effects more serious than the original condition. Every question I have suggested today is a question to bring to your prescriber, not a decision to make alone. If you are on a blood thinner alongside any of the medications on today's list, that combination carries a specific, elevated bleeding risk your prescriber needs to know about. This video is for educational purposes only. The goal is to give you the right questions so your doctor can give you the right answers for your specific situation. The colon you have after 60 is not the colon you had at 40. Its protective systems are reduced. Its motility is slower. Its immune defenses are already under load. When medications land on that system, the effects are compounded in ways that are almost never explained to patients. The 7 medications we discussed today are not villains. Most of them are doing real therapeutic work. What they are is underexplained. The SIBO from PPIs, the B12 theft from metformin, the nerve damage from laxatives, the invisible colitis from antidepressants and heartburn pills. These are not obscure findings buried in journals no one reads. They are in the research. They just haven't made it from the research to the appointment room. That gap is what this channel exists to close. If this kind of research-backed health guidance made specifically for adults like you is what you want more of, hit subscribe. Every video on this channel is built on real evidence, translated into real language for real life after 60. Before you go, tell me in the comments, what is the one health symptom you have been told to just manage that you suspect might actually be connected to something you are taking? Your answer shapes what I research and cover next. I read every comment on this channel.